am Dr. Judy Lao-Tan. You are watching the segment on how to evaluate and follow up patients with hepatitis C virus infection. When you are confronted with patients whom you are suspecting as having acute HCV infection, the initial evaluation is usually when you have clinical signs and symptoms compatible with acute hepatitis. So usually, which is the presence of jaundice, and when the ALT levels is more than 10 times the upper limits of normal. However, anti-HCV testing is the first line of diagnostic tests. Positive test result of anti-HCV usually indicate either a current, which is active HCV infection, which can be acute or chronic, or a past infection that has resolved, or a false positive test. The false positive tests are usually common in areas where there is low prevalence of hepatitis C viral infection. Once the anti-HCV test is positive, then HCV RNA testing should be part of the initial evaluation in suspected acute hepatitis C virus infection or in immunocompromised patients. However, if your anti-HCV is positive but your HCV RNA is negative, then if you want to be very sure, you should retest the HCV RNA 3 months later in order to confirm there is really a true convalescence. The AASLD in 2006 came out with a guideline on what they call one-time HCV testing recommendation. Their recommendation in the United States is there should be a one-time testing for individuals born between 1942 to 1965. The reason for this is because 3/4 of all infected hepatitis C virus infection in the United States are born in these years. So hepatitis C virus testing is still recommended in select population based on demographics, prior exposure, high-risk behaviors, and certain medical conditions. The rationale for testing on this population is because of proven benefits of treatment in reducing the risk of hepatocellular carcinoma and all-cause mortality, and also the potential for public health benefit of reducing transmission through early treatment, viral clearance, and possibly reduce risk behaviors. The most important risk for HCV infection is injection drug use. However, in the Philippines, we have no data, but from where I practice, more than 50% of our HCV infection is due to IV drug use. The other risk for these HCV infections are persons on long-term hemodialysis, healthcare individuals who have needle stick pricks, sharp or mucosal exposure to hepatitis C virus infected blood, or children born to HCV infected women, and in the Philippines, prior recipients of transfusion or organ transplants before July 1992. The reason for this is that in the Philippines, per Department of Health memorandum, all blood was required to be screened starting 1993. And also for incarcerated persons and persons with percutaneous or parenteral exposure such as tattooing, or individuals who go elsewhere for operations wherein the infection control is questionable. Because of shared transmission modes, persons with HIV are at risk for hepatitis C virus. Sexual transmission is a particular risk for HIV-infected men who have unprotected sex with men. The other conditions that you have to think of are unexplained chronic liver disease and/or chronic hepatitis, including elevated ALT levels, sexually active persons who are about to start pre-exposure prophylaxis for HIV, and solid organ donors, whether it is deceased or living, because they might cause the transmission of hepatitis C virus infection to the recipients. So I'd like to summarize using the algorithm with the AASLD that was given out last year in 2016. When and in whom to initiate hepatitis C viral virus therapy. So once you are found to be, you test for anti-HCV antibody. If you are non-reactive, then that means there is no HCV antibody detected. So you stop there. Once it becomes reactive, then you request, as I have mentioned, for HCV RNA. Once it is detected, then that means this patient has current HCV infection, and then this patient must be referred or linked to care. However, if the patient HCV RNA is not detected, then that means there is no current HCV infection. However, if you need to do an additional testing, as been mentioned in the previous slides, 3 months later, the HCV RNA should be retested in order to be sure that the patient really has no current infection. So how do we evaluate for chronic HCV infection? The general workup is usually getting CBC, prothrombin time, liver function test, glomerular filtration rate. The reason for this is that HCV infection can also affect the kidneys, and you want to do a thyroid stimulating hormone test if you are planning to use interferon. And of course, you want to get HCV viral load, genotype. The ILB28B testing is now actually has no role anymore, especially now with the oral medication that is available with the oral direct acting antiviral treatment. The other additional workup and monitoring for chronic HCV infection is that you should test also for the presence of hepatitis B virus and HIV, and you have to assess alcohol consumption, evaluate for liver fibrosis, such as doing a liver biopsy or imaging like liver fibroscan, or non-invasive markers like fibrotest or APRI. So you are recommended also to vaccinate all HCV patients against hepatitis A virus and hepatitis B virus if not done yet. And if the patient has cirrhosis, then pneumococcal vaccine should also be given. What are the consequences of untreated hepatitis C virus infection? This has been shown that if you leave the patient untreated, in 20 to 30 years' time, there is a 17 to 55% risk of developing cirrhosis. Once cirrhosis is present, then these individuals will carry a 1 to 5% annual risk of hepatocellular carcinoma development. And it also carries with it a 3 to 6% annual risk for hepatic decompensation. And of course, with this, 15 to 20% will die if with complications. So what are the barriers to hepatitis C virus treatment? One is contraindication to treatment, like presence of comorbidities, continuing substance abuse, psychiatric disorders, or short life expectancy. The second is when there is competing priority and they are lost to follow-up, and also long treatment duration and the presence of adverse effects. However, these three barriers seem to be already moot with the advent of what we call the oral direct-acting antiviral agents that are now available. The other barriers are lack of access to treatment because of high cost, lack of insurance, there is no third payer, especially in our country, lack of drug availability, or geographic distance. And the most important one is lack of practitioner expertise. And the other one is refusal to seek care. So I would like to end my segment on hepatitis C virus in patients. When you have an untreated HCV patients, they should be monitored. So monitoring of untreated patient is similar to those who failed treatment. So you have to assess the liver for fibrosis with non-invasive methods every 1 to 2 years. And if they are already cirrhotic, then hepatocellular carcinoma surveillance should be done to them every 6 months indefinitely, and endoscopic screening for esophageal viruses is recommended. With this, I would like to thank you for your attention. Thank you.